is the introduction part. Let's go further. So we will be discussing basically the association between clonal hematopoiesis, cancer chemotherapy, environmental exposures, age and smoking with relation to development of AML and MDS. So basically, by definition, the acquisition of somatic mutation in hematopoietic stem cells that multiply to a point of detection and shapes it into a pre-malignant state is referred to as clonal hematopoiesis. Now, it is such that the mutation contributes in expansion of a clone's fitness to that extent that it can culminate in malignant transformation. For example, this diagram shows you hematopoiesis normally, which is happening and leading to normal differentiation of cells. On the other side, clonal hematopoiesis involves a somatic mutation leading into malignant transformation, inflammation, and myeloid bias, which we understand by the name called CHIP. Earlier, treatment-related myeloid neoplasms were thought to develop from mutagenic effects of the cancer therapy. Like this. Here, suppose a female had breast cancer, chemotherapy was given, and at some point of time, it was noticed that she developed AML. So this bottleneck effect was observed. But recent studies now show that treatment-related myeloid neoplasm initiating cancer mutation can predate cancer therapy. They have to be consistent with clonal hematopoiesis, but their main effect should be on the DNA damage repair genes, which further lead to AML or MDS. So in this diagram, we can see that's the normal polyclonal differentiation. Suddenly, these arrows, the yellow arrows, point to a mutation, DNMT31A, then the other mutations, and subsequently it develops into CHIP, then ASXL1 develops it into MDS, further mutation develops it into AML. So in this study, it was seen that blood samples were withdrawn before and after the cancer therapy. They found to have clonal hematopoiesis, but a damage to DNA repair genes were noted, specifically related those who were converting it to AML. Now the driver genes are again, which we have discussed in the before diagram, DNMT3A, TET2, ASXL1 being more common of them, and DNA damage response genes, which are, for example, TP53, PPM1B, and CHEK2. So this is basically the pyramid which is leading it to that zenith point, clonality, clonal hematopoiesis, then indeterminate potential division of clonal hematopoiesis, that is CHIP, then that is undeterminate significant cytopenia, CCUS, leading to MDS, AML, and dysplasia and cytopenia side by side. There are certain specific external exposures also that might be influenced by these genes, like age and smoking. So it was observed that with increasing age, these genes thought to mutate and lead to AML or MDS formation. So generally, when treatment-related myeloid neoplasm are recognized, they are in two spectrums. More commonly occurs after 5 to 10 years of exposures to alkylating agents or ionizing radiations more commonly. They often present with MDS with marrow failure. And the second subset includes a relatively small population of 20 to 30% cases, and they present 1 to 5 years following the treatment, especially with topoisomerase 2 inhibitors. Anemia being the most common presentation, with its morphology characterized by macrocytosis or poikilocytosis. In WBCs, dysplastic changes are noted, basophilia is seen. Bone marrow can be variable. It could be hypo, or normocellular, and dysgranulopoiesis and dyserythropoiesis are usually present. So basically, in this article, we will be evaluating how clonal hematopoiesis in combination with cancer therapy or clinical parameters that we have discussed, age and smoking, they might help us to stratify the treatment-related myeloid neoplasms risk for patients with cancer.
Okay, so Aishi, now that you have completed the introduction, so can you just summarize, like in one sentence or two sentences, what is the problem that the authors had to face in this study?
Yes, so the problem they are facing is if they are if they are sampling individuals who have some primary cancer, so they are having clonal hematopoiesis by far, but that is a small group. Plus, they have this DNA repair gene mutations which they are observing, which is leading to AML transformation in them.
Okay. Nikhil, I think you're muted.
So sorry about that. So if I may say, Ayushi, we have to make this really simple so that people understand what's going on. So it is said that as a person starts to age, it's said that there are two things most inevitable in life. One is taxes, another is clonal hematopoiesis. So as a person starts to age, his body starts to, his body starts to fail. And the same is true for his bone marrow. To sustain hematopoiesis in a normal person, the body fights by giving a sort of a proliferative advantage to hematopoietic stem cells, which is in the form of mutations. This is more or less a healthy phenomena. We think we are not very sure why it occurs. We know that this is linked to inflammation. But in this particular study, what the authors have done is ask one simple question: is when patients have clonal hematopoiesis as well as cancer, what effects do chemotherapy have to play on the clonal hematopoiesis? Do these clones change or not? That is the question that they're trying to answer. All right, in a nutshell. Gaurav, did I get that right?
Yes, sir.
So that's essentially what they're trying to do.
Okay, so I think we can move on.
Yeah, I think we can start with the method.
So I believe Krishni is next. And for the larger audience, we will say that anything you want to ask at any time, please feel free to put it in the chat and we can see and we can get to that. Okay, Christy.
Hello everyone, I'm Dr. Christy from CMC Vellore. So my part in this discussion will be to cover the first part of the methods and materials. So before we actually go into the methods and materials used in the study, I just want to give a heads up about the MSK impact. So MSK impact actually stands for, MSK stands for the Memorial Sloan Kettering Hospital, which is a tertiary referral hospital for cancer based in New York. And impact stands for the integrated mutation profiling of actionable cancer targets. So in simpler terms, this is a tumor profiling test. So any patient with a tumor, we are actually trying to detect at least those genes which are commonly implicated in those tumors, that is the 468 gene mutations in common and rare cancers. The purpose of this is that the tumor's molecular profile can be mapped and the targeted therapeutic agent can be provided for better therapeutic outcome for the patient. So the novel part of this MSK impact gene sequencing analysis is that each tumor is always profiled with that of a normal tissue. So usually a blood sample along with the tumor are studied parallelly to identify what is a somatic variant and what is a germline variant. For example, the genome of a tumor is compared to that of the blood of tissue, and it actually helps to detect the mutations which are specific to the cancer cells when compared to that of the normal in blood cells. So this is a general list of all the mutations which have been identified or which have been included within the MSK impact panel. These genes are mainly selected because they play a critical role in the development and behavior of each of the tumors. So coming to the study, we have two cohorts. One is the MSK impact cohort and another is the serial sampling cohort. This is mainly a retrospective analysis wherein the 24,146 patients who have already had a blood and tumor sample matched or sequenced with the next generation sequencing analysis, and the data of these patients are collected. And this cohort actually further is divided into the patients who actually had their full cancer treatment at the MSK hospital, which is around 10,138, and those patients who did not have, who had their cancer treatment at an outside hospital. This differentiation is important because only in this set of patients, the role of cancer therapy in driving the clonal hematopoietic mutations were actually studied out of a total of these 24,146 patients. And serial sampling cohort is a prospective analysis wherein a repeat blood sample was taken for about these 525 patients so that we can see the changes that was happening in the clonal hematopoietic mutations between the two timelines when the blood sample was collected. So again, this actually included patients with the non-hematological cancers who underwent matched tumor and blood sequencing using the MSK impact panel. So the data was collected between December of 2014 and July of 2018 at the Memorial Sloan Kettering Cancer Center. All patients provided informed consent, and the study was approved by the MSKCC Institutional Review Board. So the data that was extracted was the ancestry, the smoking, the date of birth, the cancer history, and the therapeutic exposure data. And this was obtained from the MSK Cancer Registry and from the clinician notes. So coming to the next cohort, so as I said, this is a prospective analysis which was done in 525 patients, wherein additional blood samples were obtained for a repeat clonal hematopoietic mutation testing. So this actually helped them to study the growth rate of the clonal hematopoietic mutations over time, and the median sampling interval was about 23 months with a range of about 6 to 53 months. So some of the exclusions of the patients from the study were those who had a hematological malignancy diagnosed within 3 years before the MSK impact blood sample or the tissue sample was taken, or any patient with a hematological malignancy less than 3 months after the MSK impact sample was taken, or those with an active hematological malignancy at the time of blood draw. So as I said, one of the data that was extracted was the therapeutic exposure. So this is the cumulative therapy dose, which actually refers to the sum of all the doses which is ever received by the patient prior to the blood draw. So for example, we have the platinum class of drugs, which is a carboplatin, cisplatin, and oxaliplatin. Suppose, and the cumulative dose is given here as milligram per kilogram. And suppose patient A has received a dose of about 20 milligram per kilogram, which is a cumulative dose for that patient. He would actually be plotted here. So the entire plot is actually divided into tertiles, and the blue stands for the first tertile, the red stands for the second tertile, and the white stands for the third tertile. So based on the tertile, a score was assigned. That is, if the patient falls on the first tertile, is assigned a score of 1. If the second tertile, a score of 2, and so on. Similarly, if a patient B has had both carboplatin and cisplatin given, then each tertile score is calculated for each of the drug classes. For example, if suppose his carboplatin tertile score is 1 and cisplatin tertile score is 2, his total score will be 3. And this is further plotted on this graph, and this is further divided into tertiles, and the final tertile score is derived. And this platinum score is actually calculated for the entire cohort. So coming to the process by which the DNA was profiled for the patients. So we have these processes wherein the first is the targeted capture-based sequencing, which actually involves the DNA fragments were captured using custom probes. This is followed by the variant calling, that is any variant from the normal genetic sequence is identified. This is further followed by the post-processing filters in order to remove any artifacts or false positives, and the validation of calls in order to test the reproducibility of the clonal hematopoietic mutations. And then the variants were finally annotated as whether they were oncogenic in myeloid disease, only oncogenic. So coming to the targeted capture-based sequencing, this used the tumor and the blood sample sequenced using the MSK impact. So the DNA was extracted from the formalin-fixed paraffin-embedded tumor tissue and patient-matched blood samples. So the DNA fragments were captured using custom probes, and the 163 genes implicated in myeloid pathogenesis were predominantly studied. And a variant calling indicates that any variance from the normal sequence is identified. So they can either be small nucleotide polymorphisms, so small insertions or deletions, or single nucleotide substitutions. Those are all identified. So once they were identified, we come to the next process as to the post-processing filter of for the clonal hematopoiesis calling. That is, we have identified a variant. They have identified a variant, and so it will fall into one of the three classes. It could either be a germline mutation, it could be an artifact, or it could be a true somatic clonal hematopoietic mutation, which the authors are trying to quantify. So the authors actually set a value of that VAF stands for the variant allele frequency. That only when the variant allele frequency, that is the mutations of the clonal hematopoiesis in the tumor, was more than blood, it was considered to be significant. Whereas when the variant allele
Is that
frequency
right?
of the
What
tumor,
you're saying right now, like the box
Yes,
that you're showing, is that right?
Yes, sir.
Like the VAF of the tumor. First, can you please like explain what is a VAF for the larger audience? Like, what do you mean by VAF?
So VAF is the frequency of the mutations that was occurring in the genomic sequence.
Okay, so
That is, we are trying to identify the variant alleles. So the frequency by which, I mean, the amount of frequency by which the variant alleles are found in the tumor.
correct.
This is because the tumor has both blood, so it can have a leukocyte infiltration. So those leukocytes can have the somatic clonal hematopoietic mutations. So the VAF of the tumor should be more than the blood, because it will be a product of the VAF of the blood into the amount of leukocyte infiltration of the tumor.
Yeah, that's true.
In the blood.
That's true. But the CH mutation, you expect to see them in tumor or in blood?
In the blood, sir.
So then,
This was
so then should the VAF of the tumor be more than blood, or the VAF of the blood should be more than tumor?
no, actually, this was taken to be the true somatic clonal hematopoietic mutation, sir.
Yes, so I think it is just that the sign is not right here. So the VAF of the blood has to be more, no, because the mutation is present in blood, not in tumor. In this case, so that is how you detect the mutation in a tumor. Otherwise, like you call something somatic if the tumor has in more than blood. But in this case, our target population is in blood, right? So the VAF of blood has to be higher. So that was clear. Yeah, okay.
So in this, sorry, sir.
I think you can go ahead.
Oh, okay, sir. So in this plot, we have the percentage of blood contamination, which is plotted against the true variant allele fraction. When the variant allele fraction of both the blood and the tumor was same, it is not considered to be significant. But when we increase the ratio of the VAF frequency in the blood, like 1:1.5 or 1:2, we see that there is more precision in the the clonal hematopoietic mutations that were identified. So the variants we have identified and we have categorized, they have identified that they are true somatic hematopoietic mutations, and now they were annotated as whether they were oncogenic in myeloid disease, that is the CH myeloid putative driver mutations, that is mainly for genes which are implicated in the myeloid hematological malignancies, or as oncogenic, which is only the clonal hematopoiesis with putative driver mutations. Yes, thank you.
So I think we move to Prakriti. Yeah.
Good evening, everyone. I'm Dr. Prakriti Mishra, JR3 from KMC Manipal. I'll be dealing with the second part of the material and methods. The first part was dealt by Crispy. So in this article, sir, is my slide moving?
No, not yet.
So now, sir, is it visible?
Yes.
So as discussed by IUG, the clonal hematopoiesis is basically the somatic mutations which finally lead to chip formation, which can be caused by any malignant transformation or inflammation. So MSK impact is also one of the other entities which was included in the study. So this part has been dealt earlier. So basically it can constrain any patient consent. Sampling was done, sampling properties was done, and it was finally put into a bioinformatic analysis. Now I will be basically starting from the calculation of DN by DS ratio. So what is DN by DS ratio? Was defined as a ratio of non-synonymous substitutions, which was basically used to deal with the which was used to measure the SS of the strength of the protein coding genes, which was taken in the MSA impact in the study. Basically, DN by DS ratio is used to study the patterns of selection on the protein genes, which can be seen in small genomes of viruses, bacteria, and other eukaryotic genomes. In this study, the authors have quantified the missense and the truncating mutations at the MSA impact at the genomic level and found to be a significant level of around Q to be less than 0.1, which was done after multiple testing corrections, including more than 25 variants. So it's not moving.
Okay, it's not moving for us also.
Maybe just click in the center of the screen. Click once or twice in the center of the screen.
Yes, sir.
No, not moving.
No, sir.
Should you do it from your end, Priya, like the slides?
Yeah, I can share. Yes, sir. Now it's
Okay.
okay. So basically, the formula for calculation of by this ratio taken in the article was N was taken as non-synonymous change or substitution. S was the synonymous changes. So the PPT is not.
I think it's hanging basically. It's probably better if Priya shows her screen and you can just present.
Yeah, I'll share the screen.
Yeah.
Hello. Hi, am I Dr.
Is there a problem sharing your screen?
No, I'll share
Yeah.
once again.
So Pratik, let me ask you this while Priya is sharing. So why do you think, I mean, do you understand this concept of DNTS issue and why it was done in this paper? I mean, it's a small part of the paper actually.
Yes, sir. It was just to calculate the non-synonymous substitutions to the
Why
comparison.
why would you like to do that? Like, in any
So-
particular position of the genome, non-synonymous versus synonymous, why would you like to do that?
So basically, in this study, it was done to quantify the Q value, which could, if it is taken as less than 0.1, then, sir, it was sent to have an association of the modeling effect of the clonal hematopoiesis as compared to the cancer therapy, or there can be any history of prior exposure or any age or sex relation and the variant factors that was related to the participants in the studies.
Is the screen visible?
Yes.
Yeah.
I think we can move ahead. She was in third slide probably.
Yes.
Next slide.
Yes.
Next.
So the formula taken in this article was DN by DS ratio was the rate of the non-synonymous changes of the substitution of the various genes that was included in the MSA impact genomic level over the rate of the synonymous changes of substitutions in the study design. Next slide. So the other methods used was the modeling association, which was seen to be affecting the clonal hematopoiesis and the history of previous cancer therapy exposure. So the type of study design used was a multivariable logistic regression, which was seen to have a positive association. And all the clonal hematopoiesis evaluation was done in specification to the various specific factors. It could include the age of the patient, the sex of the patient, and any prior history of smoking. There was no clear cut demarcation or evidence of any time dependency or latency between the clonal hematopoiesis driver mutations and any cumulative exposure to therapy, as discussed in the first part. So there was multiple hypothesis correction for the analysis to test the association, and it was seen to be having a positive association between clonal hematopoiesis and previous cancer therapy exposure. Next slide.
So Pratik, did you realize about this concept called multiple hypothesis correction? Like, I just wanted to point this out because it is a statistical concept only, but just because it may be important for a lot of people. Like, why would they do a multiple hypothesis correction? Did you realize that?
So basically what I understood was there was a number of variant factors that was affecting the clonal hematopoiesis that could include the previous history of cancer therapy, any age of the patient, the specific time period of the onset of the disease, any local metastasis or distant occurrence of the disease. So that is why a multivariable logistic prospective type of study was needed for this modeling association.
Yeah, that is true. But I was asking about the multiple correction thing. So the concept here is that when you study multiple factors, like for example, in these days you will have gene panels of 100, 200 genes. So you are studying association of each gene with some parameter, let's say with the clonal, with the cancer therapy or with age, something like that. So then just by chance, some of them might come as significant, right? Like if you are dealing with a 5 parameter, like 5 genes only. So chances that somebody will be just by chance significant is less. But if you are taking 500 genes, so then some of them can be just positive, showing you a significant p-value just by chance. This may not be true, this association. So in this large kind of data set, when you're testing for multiple parameters, you need to do this correction. Now this is important for those who might be doing studies with multiple parameters. So they need to do this kind of correction because just to avoid this chance factor.
Okay, sir.
You can go ahead.
So the multivariable logistic regression analysis was basically done with 2 sample sizes. One was clonal hematopoiesis positive individuals, and one which had mutational and multivariant factors to assess the positive association between them. Next. So thus the authors could correlate the clonal hematopoiesis and the VAF mutation, that is variant allele frequency, between certain selected individual which could display the certain clinical and mutational factors and could exclude them from the clonal hematopoiesis positive individuals, which could be done by ordinal logistic regression to assess the certain clinical characteristics which were seen in certain set of population, and to assess the increased incidence, that is the p-value greater than 0.5 was seen for clonal hematopoiesis mutation number analysis. Next slide. So now the third entity was the modeling of the effect of the cancer therapy on the mutation rate. It was further defined by a formula which was given as alpha is equal to log V by V0 divided by T minus T0, in which the T and T0 was age of the individual at different two variable points for the estimation of the mutation rate, and V and V0 was the variable allele frequency or VAP that was taken at different time intervals at T and T0 respectively. This formula was incorporated in the study to equate the equation which could help in assessing the exposure to cytotoxic therapy for the patient, to define the prognosis of the external beam radiation therapy, and to define the mutation growth rate. And along with this, the authors also established a paired t-test significance which could assess the difference between the growth rate of DDR mutation as compared to the non-DDR mutation on the patients who were on therapy, and also compare a significant amount of sample population with the patient not on therapy during the follow-up period, and to check for the effectiveness of the mutation rate and the clonal hematopoiesis. Next slide. So there is the image which was assessed to combine the analysis for AML versus MDS risk. In this, variable factors were included, like mutations in the neoplasm driver gene was included. There could be a possibility of inclusion of genes which do not have any chances of non-myeloid neoplasms. There could be there was inclusion of the silent mutations. Proportion of mutations was also seen having major functional category effects, and a variable factor of single nucleotide variants, that is SNV, was included to signify the proportion with specific nucleotide changes as compared to the clonal hematopoiesis levels. Ma'am, next slide. So the authors used a univariant specific regression coefficient curve in which a Cox proportional hazard regression was estimated, which was done to specify the estimation of maximum VAF value, the total number of clonal hematopoiesis mutation, and the specific genes and blood count parameters were taken into consideration, which could be adjusted according to the age and sex of the patients. In example, the patients who suffered with any solid tumors. But however, the limitation for this was the study could not affect or study the gene treatment interactions and could not assess the risk of increased myeloid neoplasia because of the limited sample size which was seen on the patients which had any history of prior cancer therapy. Next. So the other entity dealt was the modeling absolute risk of AML versus MDS, which was basically done to establish the cutoff of VAF, that is variant allele frequency, which was taken to be more than 2%. In this diagram, we can see that there was divided, the patients were divided into newly observed and complete loss. So newly observed on treatment were around found to be 13 patients, whereas on treatment and complete loss was found to be 4. And on follow-up, it was found to have the initial VAF value of more than 2%. And next. Now, the other entity that was included was AML or NDS and other solid tumors malignancy as seen, in which an ICARE-R package was used, which included entities like multivariant HR estimates, which took into consideration the maximum VAF value, the gene-specific effects, the peripheral blood count indices using the HD estimation of the patient, the RDW, at the age-specific AML and MDS risk and rate transformation seen in patients suffering particularly from breast cancer in female patients, to access the mortality rates of women with breast cancer, to study the distribution of clonal hematopoiesis VAF value, the number of mutations, the clonal hematopoiesis genes, and blood count indices were taken in which there was no prior treatment to the patients before any blood drawn was done for VAF therapy. Next slide. So the advantage was found to be that the impact population that was studied in this article captured the interpersonal relationship and established a positive co-association between the blood count indices and the clonal hematopoiesis mutational features. However, there was a development of a risk model which gave an additive association on the log scale of the clonal hematopoiesis mutational features like age, the sex, the prior history of therapy, to develop the cancer therapy and its risk in entities especially related to therapy-related myeloid neoplasm. Next.
Okay. Nikhil sir, I want to say something. Prakriti, like methods have ended. You can muted, I think, Nikhil sir.
I said I'm okay. I don't have anything else to add.
Okay. Okay, so we'll go to the result now. We start with whom? Okay, Nupur.
Hello, everyone. So I'll be dealing with the first part of the results. So firstly, the first aspect that was dealt was the molecular characteristics and the clinical determinants of clonal hematopoiesis. Using a prospective targeted sequencing data, a total of 24,146 patients were enrolled, and various parameters such as smoking, gender, age, ethnicity, therapy, and 56 types of solid primary tumors were studied, to name a few: ampullary, anal, appendiceal, biliary cancers, and gastrointestinal stromal tumor, germ cells, and glioma. It's a long list of 56 solid tumors that were studied. Using a stringent workflow, a clonal hematopoiesis variant was estimated in blood. It was seen that in 7,216 individuals, which amounted to 30% of the total, there was presence of clonal hematopoiesis mutations, and these showed 11,076 types of unique clonal hematopoietic mutations. The median VAF of this mutation was 5%, and it ranged from around 2% to 78%. The patients having clonal hematopoiesis, it was seen that one mutation is present in around 69% of the patients, and 2 or more mutations were seen in 31% of the patient. It was seen that over half of the clonal hematopoietic mutations were actually those in the putative driver mutations, and the clonal hematopoietic putative driver mutations were those genes which are recurrently mutated in myeloid neoplasm. Therefore, the myeloid putative driver genes showed an odd ratio of 1.3 and a significant p-value, telling that the mutation in myeloid driver genes and the clonal hematopoietic putative driver genes are strongly associated. It was seen that the VAF of a myeloid gene and that of mutated driver gene are comparatively more to the non-myeloid and the non-mutated driver genes, and the VAF of patients having more than 2 mutations was higher as compared to just a single mutation. And the commonly mutated genes were the DTA genes, that is the DNMT3A genes, the TET2, and the ASXL1. So summarizing what I've spoken till now, that the genes which were commonly mutated was myeloid, that was basically the myeloid putative driver genes, and there was a missense mutation. So this tells there is a strong enrichment of the myeloid genes which takes place, which tells that the basic hematopoietic progenitor stem cell has a fitness advantage over the other oncogenic solid tumors. Now coming to various other factors such as ethnicity, Asian population was at a lower risk of developing clonal hematopoiesis. Those patients who had a previous history of smoking or were a current smoker had an odd ratio of 1.2 and had a significant p-value. And those who were undergoing any therapy for these cancers had an odd ratio of 1.2 and a significant p-value, telling that both smoking and therapy are related to clonal hematopoiesis. Now, there was the spectrum of mutations which was seen in all the cancers were almost same, but there was a significant increase in DNA damage response gene mutation, that is PPM1D, TP53, and CHEK2. And this PPM1D mutation was more frequently seen in patients having ovarian cancer, which we can see by this lavender color, and in patients having endometrial cancer, which is seen in this pink color. Now, coming to the second aspect which was studied was the clinical parameters which shape the fitness landscape for clonal hematopoiesis. It was seen that the patients having these mutations of PPM1D, TP53, and CHEK2 were significantly higher in those patients who were undergoing treatment. As we can see, those patients who are undergoing treatment have a higher level as compared to those who are not going under any treatment. Now, secondly, while it was seen that clonal hematopoiesis defined by mutations in epigenetic modifiers such as DNMT3A and TET2, or splicing regulators such as U2AF1, SRSF2, or SF3B1 was not strongly affected by the exposure to therapy. As we can see, the proportion of patients along the various age groups among the untreated and the treated almost shows similar distribution. It was seen that the spliceosome genes, that is the SF3B1 and the SRSF2, had the strongest association with age. We can see that the odds ratio was higher as compared to the rest of the genes. The other genes were also associated with age, whereas DNMT3A had a lowest association with age of these patients. Now, coming to the next parameter, which is therapy, it was seen that the DDR genes, that is the DNA damage response genes, were strongly associated to any previous exposure to cancer therapy. We can see that all the three genes have an odds ratio which is higher as compared to the rest of the genes. Now, coming to the third factor, which is smoking, it was seen that ASXL1 had a significant association with a history of smoking, and it has the highest odds ratio. Now, coming to the therapy, it was seen that patients who had therapy in the form of radionuclide, external beam radiation, or cytotoxic therapy had a more severe association as compared to those getting a targeted therapy or an immunotherapy. And when coming to the subclass of therapy, it was seen that topoisomerase 2 inhibitors, patients who were getting this topoisomerase 2 inhibitors had an higher association. And among those getting platinum-based therapy, it was seen that carboplatin had the maximum association. Now, coming to the involvement of genes with various therapies, it was seen that PPM1D gene was maximally associated with radiotherapy and with platinum-based therapy. In addition, it was also associated with external radiation, topoisomerase 2 inhibitors, and taxanes. The TP53 gene was associated with external beam radiation therapy, platinum-based therapy, and taxanes. And the CHEK2 mutation was associated with platinum-based therapy and topoisomerase 2 inhibitors. Among it was seen that clonal hematopoiesis putative driver mutations was more oftenly associated with a higher cumulative therapy dose of carboplatin and cisplatin amongst the platinum-based therapies as compared to oxaliplatin.
So is that your last slide?
Yes, sir. Yes, sir. I've dealt with the first half of results.
Okay. So can you maybe summarize your finding in like 1 or 2 lines?
Yes. So amongst the various confounding factors which was studied, it was seen that smoking and age had a higher association. And with smoking, with all these confounding factors, there was involvement of certain genes. For example, in smoking, it is ASXL1, which is seen. And amongst the genes which were mutated in patients having clonal hematopoiesis, it was seen that further these mutations are basically those mutations which are seen in cases of myeloid neoplasms, the genes which are recurrently mutated in myeloid neoplasm. So there is a survival benefit which this hematopoietic stem cell progenitor cell has over the rest of the factors, which leads further on for these patients to develop myeloid neoplasms in future.
So can I, is it okay to speak now or should I wait? Gaurav, can I say a few things?
You can, sir.
So how is the observation that these patients have mutations in genes which are predominantly seen in myeloid neoplasms any different from the concept of CHIP elsewhere? Why does this merit a publication?
Because patients which have clonal hematopoiesis need not definitely in future lead to any kind of malignancies. Like we know CHIP can be it's a normal phenomenon which can be present. But in this study, they have basically established that fact which is seen in individuals.
That is well known. Why have a paper in it in 2021 when this has been well known since 2014?
So they've tried to study various aspects, the confounding factors which play a role.
Exactly. So what is important here is not to note the observation that genes which are present in myeloid malignancies are also present in CHIP. That is well known. But what is important here is to note that these mutations are not different from rest of the other population. They also have DNMT3A, TET2, and ASXL1. But what is unique about this cohort as compared to other patients who have become older or other CHIP cohorts? What is unique about this cohort?
So that they are developing certain mutations which is
So they are all developing chip-related mutations, but there is something that has been given to these patients, right? What is it that has been
cancer
given?
therapy.
Correct. So this is a cancer cohort in which the patients have been specifically treated with all kinds of chemotherapy. They are, remember, the big picture is they are trying to see what effect does cancer therapy have on patients who have clonal hematopoiesis. So one of the observations is that yes, patients who have clonal hematopoiesis, it have mutations in myeloid malignancies, but that is obvious. The most important thing here is it's not just the cancer, but it is the clinical, it is the environment or the milieu in which the cancer is allowed to flourish that causes these mutations to behave differently. And this milieu is what they have studied, and they have identified that patients who've been treated with radiotherapy, patients who've been treated with platinum-based chemotherapy offer a fitness advantage to clones, especially when they have mutations in PPM1D, CHEK2, and the other one, right?
Yes, sir.
And TP53. So that is the takeaway message. Not that mutations are there in myeloid genes, that is well known, but in that it is not just chip that develops. What you do to the body, what happens to the patient, the cancer cells, what he's exposed to, will have an important role to play in cancer or progression or these chip clone progression. That is the big picture.
Yes, sir.
Okay, I think we'll go ahead to Deepali now.
Yes, sir.
Yeah.
Good evening, everyone. I'll be continuing with the second part of the results. So, clonal dynamics of clonal hematopoiesis in response to cancer therapy. So, on the basis of the retrospective analysis, it was seen that exposure to cancer therapy results in a higher likelihood of clonal hematopoiesis, especially with mutations in DDR genes. So, in the 525 patients with solid tumors, sequential sampling was done, ranging from 6 to 53 months, out of which 61% received cytotoxic therapy or external beam radiation therapy, and 39% received targeted therapy or immunotherapy or were left untreated. So as we can see here, from the point of diagnosis, the patients underwent different types of therapy, and 218 of those patients received no therapy. So the time of the first sampling, 508 patients underwent MSK impact gene analysis, and clonal hematopoietic gene mutations were detected. And then after a period of 1 month, clonal hematopoietic genes mutations were detected in 17 patients. So none of these patients developed secondary hematological malignancies during the follow-up, and the majority of clonal hematopoietic mutations were present at both points of time, which enabled the authors to study the evolution in the presence or absence of therapy and whether the clone-defining mutations influence the clonal size or not. So the clonal size remained stable in 62% of the cases, and a significant growth in 24% of the cases, and only 10% showed a decrease. So as we can see here, on the basis of different therapies that were taken, cytotoxic therapy and radiation therapy showed the most growth as opposed to the untreated or the targeted or immune therapy treated patients. So out of the as compared to the other genetic mutations, those that had DNA damage response genes, those who received cytotoxic therapy, the treated ones, they showed a significant increase in the mutations, and so did the ones with radiation therapy as opposed to the untreated patients. So we can see here that PPM1D and TP53 and CHEK2 showed a significant rise in their growth rate as in the treated patients as opposed to the untreated patients. So patients with multiple mutations exhibited a faster growth in clonal hematopoiesis as compared with those who had only one mutation, regardless of whether the patients were untreated or treated. 34 patients had at least 2 clonal hematopoietic mutations. One was a DDR mutation, and the other one and another mutation, which served as a control and also removed any confounding bias. So 10 patients received treatment, and 10 patients did not receive treatment, and 24 patients received treatment. And we can see that in the treated patients, these connecting lines show that there is an increased growth in the DDR genes. So the data provided direct evidence in patients that cancer therapy selects for clones with mutations in the DDR genes like TP53, PPM1D, and CHEK2. These clones have lower competitive fitness and more adverse outcome relative to non-DDR genetic mutations in the absence of cytotoxic or radiation therapy. Moving on to genetic and clonal evolution in therapy-related myeloid neoplasms, the hypothesis stated that TMN development is at least in part mediated by therapeutic selection of mutant clones in a gene-dependent manner. 35 cases for which paired samples were available, one sample at the time of molecular profiling for the primary cancer and the second at the leukemic transformation. There was a median intersampling time of 24 months. So out of the 34 cases, so out of which 34 cases had disease-defining events at the time of TAMN, and 19 cases only one mutation was present, and 13 cases 2 or more mutations were present. So here we can see that the TP53 variant allele frequency increased over a period of roughly 3 years, and MDS occurred around at the age of 78. And as previously mentioned, if there are 2 or more mutations, there's more increased chances, and MDS occurred around 69 years of age. All cases had the clonal hematopoietic mutation at the time of TMN diagnosis, but that in itself was insufficient for leukemic transformation. So further studies showed that 91% of the cases, transformation was associated with the acquisition of additional somatic mutations like KRAS and NRAS, known to drive late progression to myeloid disease. nearly half of the patients had a TP53 mutation, that is around about 40% of the cases. In the presence of therapy, TP53 clone had consistently attained dominance by the time of therapy-related myeloid neoplasms. 92% of the cases with available karyotype TP53 mutations co-occurred with isolated chromosomal aneuploidies or complex karyotype. So this proves a direct mechanistic link in which the cells carrying the TP53 mutations are positively selected due to an exposure of oncologic therapy. So then they attain clonal dominance, and due to the lack of its tumor suppressive action, there is more genetic diversification and hence increased risk. Clinical implications of clonal hematopoiesis in patients with cancer: 9,437 cancer patients exposed to cancer therapy were selected, and only 75 developed therapy-related myeloid neoplasms. Cause-specific Cox proportional hazard analysis showed that CH present at a VAF of more than 2% was associated with an increased TMN risk, and the strongest associations were observed for mutations in TP53 and mutations in the spliceosome genes, as mentioned previously. So this is a comparison graph between the primary AML occurrence and the secondary AML, which is the therapy myeloid neoplasm. So it suggests that the relative risk of myeloid neoplasm associated with clonal hematopoiesis and related parameters is similar between the healthy individuals and the patients with cancer. So there was an evaluation also of clonal hematopoiesis in combination with clinical parameters such as age and peripheral blood counts to help stratify TMN risk for patients with cancer, and it was seen that mean corpuscular volume showed an increased risk. In the absence of any prospective clinical data, which was unavailable, they created a synthetic model to quantify the risk of AML and MDS for women with breast cancer. Combined estimates of parameters obtained from the multivariable analysis with the distribution of CH mutational features and blood count parameters from untreated patients were taken, and a model of 10-year cumulative absolute AML MDS risk distribution for women with breast cancer aged between 50 to 75 years in the United States was created. It showed that with the presence of cytotoxic therapy, there is an increase in the absolute 10-year risk, as we can see here in this box and whiskers plot, and as opposed to those who did not receive any cytotoxic therapy. So the absolute survival benefit of adjuvant therapy is modest due to the risk of subsequent TMN. Like if you, regardless of whether you're giving with therapy, it is going to increase TMN risk, and TMN is almost always fatal with a 5-year survival of only 10%. The majority, 96% of the patients with breast cancer have a low 10-year absolute risk for myeloid neoplasm, and adjuvant chemotherapy increased the absolute risk of myeloid neoplasm by approximately 9%. So even though this did not give us any direct clinical implications, it has given us a rationale for future studies to formally estimate the benefits of risk-adapted treatment decisions in patients with cancer and with clonal hematopoiesis. So it gives us a direction to head into. Thank you very much.
Thank you, Deepali. So I think we'll finish the discussion and then maybe we can discuss. Sarah?
Yes.
Good evening, everybody. Today I'll be discussing about the discussion portion of the. So let's go again and see what is the problem statement and the aims and objectives of the authors, and what is the particular novelty of this study. Then I will also talk about from normal to abnormal, how do genetics, epidemiology, and how does the complex.
Voice,
Sarah, I think we are losing you.
Yeah, your voice is breaking.
I don't
Am I
think.
audible?
You're audible, but it breaks in between. Are you sitting close to your Wi-Fi connection or a little far away? Or you want to change your...
It's close.
Yes, okay, then carry on. I think
It's better now. Let's see. Yeah.
Okay. So let's talk about the role of clonal hematopoiesis in early detection, and about cancer therapy and the role of clonal hematopoiesis, and finally, what is the conclusion that the authors have reached. So what is the problem statement? So studies in the past were limited in the sense that clonal patterns were discovered only at the time of diagnosis or progression of the disease, but there was a lacunae understanding about early oncogenesis. And of course, there were lacking longitudinal and genetic studies and exposures. So that is why we could not get any idea about early oncogenesis. So the aims and objectives of this, so I'm just repeating this so as to not lose sight. Clonal exposure, and to determine how cancer therapy shapes patterns of selection, and basically how this contributes to the progression to overt leukemia. So in that sense, we could study a big pattern and second how information is. And there were previous that were done in neuroscientific models between cancer therapy and this study was done on humans. So how does the cell transform from normal? Can I continue?
Yeah, but your voice is breaking.
Yeah, voice is breaking a little too much, but now I think it's better. Let's go and see.
Okay, so from normal to abnormal, basically, what are the three things that have an interplay among themselves? So there's genetics and epidemiology, and these two, along with environmental factors, will help in the progression of a cell from normal to abnormal. So we all know about the Darwinian theory of evolution. So basically, survival of the fittest. So certain survival advantages have to be provided to a normal hematopoietic stem and progenitor cell in order that it becomes a fitter cell.
So this is enabled by interaction with environment, including age, ancestry, smoking, and cancer therapy. So what the authors have done is they've tried to suggest how and at what stage does this interaction occur and how does it enable malignant transformation. So rate of a mutation is basically determined by the fitness advantage that it proffers and certain parameters that help in the preferential selection of mutations. For example, smoking helps in the preferential selection of ASXL1 mutations. Cancer therapy preferential selection of EDF mutations. So, all of this highlight the importance of early detection disease and as stressed before, clonal hematopoiesis is preclude to.
Sarah, your voice is breaking. Either you go very slow, or you'll have to do something. Otherwise, we can't hear you. Yeah, maybe you can go to the last slide quickly. Yeah.
Sir, otherwise I think maybe you can log out and come back because it's really breaking too much now.
I'll just try once more.
Don't end the meeting. Leave the meeting and join again. It'll take half a minute. Leave the meeting and join again. Hello, Sarah. You left, yeah. You can take over. Kunal, Nikhil.
Nikhil muted, I think.
I can hear what's going on, but I mean, I can hear this, what Sir said. I couldn't understand anything what she was talking about. I think the net connection was bad. So let's just summarize the paper. No, I mean, I don't know who has got the slide control. We can just take it to the end. I mean, is there anything really overwhelmingly, important in this? Who's got the slide control? Do we have the slide control? No?
I don't think so. I think we need to stop the sharing. No, Priya, can you do that?
She should have stopped screen sharing.
Okay, let me try this next.
Maybe we'll tell Ruchi.
Ruchi.
I'll tell her.
Maybe we can just discuss the paper. I mean, we can just have a discussion. I've found this paper particularly interesting. It is such a unique cohort. What makes this paper unique is that the way MSKC impact is structured, that you have to get a blood sample along with the tumor sample. Not many institutes, actually, not many centers, wherever they are, encourage this sort of paired sequencing. So this is what permits them to detect germline mutations as well as say with confidence that such and such is likely to be clonal hematopoiesis or not. It's a very interesting cohort, and 24,000 samples is a huge number of cases, to begin with. It does add a lot to our knowledge of what chemotherapy is important. We have seen patients with platinum chemotherapy, I think Gaurav would remember, of breast cancer patients who developed PPMD1D mutation. So these patients need aggressive monitoring and they need immediate cessation of platinum-based chemotherapy, because if you don't stop this chemotherapy, they will develop myeloid malignancies. So patients with breast cancer, if they have cytopenia and if you detect a PPM1D mutation, you have to stop platinum chemotherapy. Same for ovarian cancer. So we've seen this in patients where a patient had PPM1D and a PARP was given a PARP inhibitor, which kind of accelerates this process.
Yeah.
So anybody else want to say anything about the paper? Anybody from the participants, what do they think?
So I think like you mentioned about the cohort, so that I think I found it to be the most fascinating, like how they address the issue of studying early leukemogenesis, because like in a healthy population, it is impractical to just study them longitudinally and see who are developing myeloneoplasm. So they got around that issue by selecting a cohort which is anyway coming to you in hospital, which is this cancer patients, and then following them. So that was I think it's a very innovative way of.
So people say, what will you get by studying CHIP? So these cohorts are proof that you need to have CHIP clinics in your hospital, because patients who are sick and are going to follow up with you anyways, you study them and see whether for a same disease, does clonal hematopoiesis change anything? And because if you find evidence that it can, the next question is, okay, what can you do about it? And those sort of studies can only be answered with this evidence that you generate.
I have a question. Okay, so I think Bini is asking that is there any specific reason why PPM1D was associated with only specific type of therapy like topoisomerase inhibitor and platinum-based therapy? Don't think there is any biological answer to it. Means it is just the association they found. Nikhil sir, you want to add anything?
I'm thinking.
Yeah. So that is I think one of the advantages of this paper, that they were able to like study gene at gene level and how like therapy also affects only a certain subset of those genes, not all genes. So all CH are not similar. So that was also clearly.
So I remember this very, very vaguely, that PPM1D is sort of is involved in regulatory feedback in TP53 pathway or something. Yeah. So if this particular gene gets knocked out, it perhaps causes the cells to behave more badly. I don't know. I'm just rambling on, I guess.
Okay, so do you have any other comments or any other questions from anyone? So for the students, like, did you enjoy the paper, and what if any of you want to say something and anything, maybe some critique you found on the paper, like something that was you thought was not right or you could do it better? Anyone? Like Nupur, Dipali?
Students have run away. Where are students?
They're there, but they're muted.
I think, sir, it was perfectly done. But then the only thing which I felt, because MSK Impact has just certain proportion of genes which they study. Maybe if they could study more and they would have found out various other, I mean, it's a lot, but there can be association of various other genes also, not only just those which they did.
Nupur is asking for whole exome in all cancer patients.
Yeah, I think
Exactly what
that
you're
is
asking to.
shorter.
So money is a very important factor. No, they've done what 24,000 patients, 400 gene panel. So just imagine an exome would be. Well, actually, exome would make it impractical because you wouldn't get the necessary depth to get low-level mutations. They're detecting mutations at about 2%, which would be very challenging with an exome. You know, with this scale of samples. So yes, it is desirable, but you know, it would not be very practical.
Sir, there was this part in the results where they said that the risk of a primary AML and then the risk of a secondary AML is similar, like therapy-related myeloid neoplasm. So, like, I didn't really get that. Then doesn't that defeat the whole purpose of the study? When they're saying that cytotoxic therapy will actually increase the risk, then like I don't understand what they were trying to say in that exactly.
So I think this cohort is limited by the fact that very few number of patients have actually developed myeloid malignancies.
Yes, 75.
To the best of my knowledge, only 35 patients in their whole cohort developed therapy-related myeloid neoplasm. Is that correct?
75, sir. Yes.
Okay. Okay. So so there is a whole spectrum from straight away developing AML to having therapy-related MDS or therapy-related MPN, and then transformation to AML. I think that's what I can say. That, you know, maybe the follow-up wasn't so much.
Okay, sir. Okay.
Gaurav, any comments you have?
Yes, so that was, I think, more from a population perspective they said. So if you take a healthy group of patients, these patients are already cancer patients, right? They have a solid cancer patient. But the proportion of CH and associated with the TMN, if you see, so they are more or less similar. So that was the point they're trying to make, that this cohort may be a representation of the full population. Because you don't really see any difference between a solid cancer and healthy population in terms of their chances of developing myeloid neoplasm, like based on what kind of CH they have.
Okay, sir. Okay, thank you, sir.
So most important is, you know, the take-home message that it is not just clonal hematopoiesis, but the environment in which it is fostered is what matters. So the environment context here being smoking for ASXL1, platinum-based chemotherapy and radiotherapy, or for PPM1D, CHEK2 and TP53. That is what you need to take home, is what I would think of.
Yeah.
And that is its contribution to literature, this paper.
Okay.
So, as residents, have you all been exposed to some form of genomic medicine? Do you see panel-based sequencing? Do you see reports in your institute? Are you exposed to that kind of stuff?
Yes, sir.
Dipali is from which place?
AIMS, sir.
AIMS. So do you guys report panels and stuff?
We don't really report them, sir, but then they're included in parts of people's thesis and things like that. So then we do have some exposure to the equipment and how it works and all that.
Very good, very good.
Same for us. We don't report it as such, but then yeah, we are taught about it.
Okay. And Nupur is from which place again? PGI.
PGI. Sir.
PGI. And the rest of you are getting there. Okay. 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 All right. Gaurav, if there are no more questions from anyone, we can.
Yes, I think there is no more question, as I can see in the chat section.
From audience also, I don't think we've had any questions. They were probably.
We get just one question.
Okay. Okay. And Sumit sir would like to add anything, or he's.
Nothing. I know nothing of genomics. If you are finished, if you guys are done, thank you, students, for.
Nikhil, sir, excuse me, sir. Sir, Sarah has joined back. Should we ask her to continue with the discussion part?
It's okay now.
Okay, discussion.
Okay, discussion. Sarah, just join us in the fun now. So thank you, students,
You can add anything if you want, like any point you want to make, you can say.
Yeah, Sarah, you want to have the last word? You can go ahead.
Hi, Sarah.
The connections might not be good even now.
My daughter Sarah, you know, she always has the last word. So even here, Sarah can have the last word.
I think Sarah is not there.
Yes,
She's not there? Not there? Okay.
Anyway, so thanks, students, for actively participating in this difficult